The views expressed on the Jerry Cahill CF Podcast are that of Jerry Cahill and guests, and not necessarily those of the Esiason Foundation. Nothing on the Jerry Cahill CF Podcast should be considered medical advice. Such advice can only be given by a physician who is experienced with cystic fibrosis. The Esiason Foundation, Jerry Cahill and guests cannot be held responsible for any damage which may result from using the information on this podcast without the permission of your medical doctor. You're listening to the Jerry Cahill CF Podcast presented by the Esiason Foundation and jerrycahill.com.
Welcome to Jerry Cahill's CF Podcast series. This show, Pulmonary Exacerbations and the Impact of Inflammation, was made possible through an unrestricted educational grant from Corbus Pharmaceuticals to the Esiason Foundation. Today you will meet Dr. Dr Flume, the Professor of Medicine and Pediatrics and the Director of the Adult Cystic Fibrosis Center at the Medical University of South Carolina since 1993. Dr. Flume is recognized by the national and international CF community and is the founding co-chair of the CF Foundation's Pulmonary Practice Guidelines Committee. He also leads a very busy clinical research program for CF and has a big interest in determining optimal management for pulmonary exacerbations.
I'm Dr. Flume. I am the director of the Cystic Fibrosis Center here in Charleston at the Medical University of South Carolina. Came here 25 years ago to set up the first adult program in Charleston. So I have been involved in the care of CF patients and research involving medications for CF patients for the last 25 years. When I was in residency and doing internal medicine, developed an interest in pulmonary and critical care. And so when my wife and I were looking at fellowship programs, for several reasons, I chose the University of North Carolina at Chapel Hill. UNC was a major CF center at the time and also involved one of the early programs doing transplantation for cystic fibrosis patients. So very early in my training, I was exposed to, got immersed in working with people with cystic fibrosis. This is a chronic disease. It's a persistent challenge, whether we're talking about sinus issues, gastrointestinal, nutritional issues, pulmonary issues, or some of the other complications that our patients live with. But if I only focus on the pulmonary for the moment, they live with chronic infection of the airways. The inflammatory response is excessive, so they're making lots of secretions that are now blocking those airways. Those have to be cleared. That causes cough, sputum production, sometimes chest pain living with that. And then there are the complications that can occur. The progression of disease, other more acute complications like pulmonary exacerbations, which leads to other interventions. A pulmonary exacerbation is best defined as a clinical worsening of a patient's underlying lung disease. So, although we don't have a specific definition and clear criteria so that we can all be making the same diagnosis in our patients, what we generally think of it is a person lives with daily symptoms of cough and sputum production, and what we're talking about now is that is worse. The most common symptoms of a pulmonary exacerbation are cough, increased sputum production, fatigue, and loss of appetite. And we worry about that last one because it's associated with weight loss. Now, there's a reason that we don't have a specific definition, and that's because not all exacerbations are the same. They might have different causes. Some are acute, like with a viral infection. Some are more chronic. They've been sort of developing progressive accumulation of sputum in their airways. The nature of the problem in CF creates an environment by which mucus and secretions don't clear out of the airways very easily. And the way we then respond to it is with inflammation. Inflammation needs to resolve. Under the normal circumstances, inflammation develops, healing takes place, and then it needs to resolve. It needs to settle down back to normalcy. In cystic fibrosis, the inflammatory response is excessive. It's more than you would see for any other person with an infection, and it's persistent. It doesn't resolve. That inflammatory process is ongoing. And the weapons that the inflammatory cells use to deal with the bacteria, unfortunately, are also harmful to normal cells. And so with that excessive inflammation, it's causing injury to the airways. That leads to remodeling, it leads to further damage. You get dilation of the airways, bronchiectasis, makes it harder to clear that infection out, and eventually is resulting in progressive loss of lung function. Now, there are therapies or medications that do address inflammation and that are used with frequency in patients with cystic fibrosis. Corticosteroids, steroids, prednisone, solumedrol, methylprednisolone, these are used with frequency in our patients with CF. Keep in mind, these patients are living with this chronic smoldering inflammatory process that is likely heightened. It's worse because of the setting of an exacerbation. So when we think about our treatment, it is in general an amplification of our normal daily therapy, more airway clearance, perhaps other methods of airway clearance, the use of antibiotics, steps to try to reduce the burden of infection and inflammation. A lot of our therapies that we use in CF really are addressing what I would call the downstream consequences of the underlying condition. So when you're dealing with things like infection, inflammation, obstruction, they're not fixing the basic underlying problem, but they are important to try and improve one's health, the way they feel, improving their lung function, prevention of complications. So these therapies have been recommended in the guidelines based upon some modest improvements in lung function and some reduction in pulmonary exacerbations. One of our goals of therapy is to improve their symptoms, their cough, their breathlessness, their pain and discomfort. But many of these exacerbations are also associated with a reduction in lung function, and that drop in lung function can be considerable in some patients. We also have good knowledge that even with what is presumed to be standard and effective therapies, many of those patients don't recover that lung function. A couple of papers that we have published have shown that only 50% of patients will actually get all of their baseline lung function back. Now, in terms of how frequent are these events, we can look at those and say, well, patients as a whole might have one event a year or one event every 2 years. But there are patients that we take care of who are having 2, 3, 4, even more exacerbations every year. There has actually been considerable work trying to understand inflammation in these patients. So why is it excessive? Why is it responding in this way? And are there steps that we can look at to try and alter that process, to try and fix that? I can't stress enough the value of partnering and listening to our patients. We have a lot to learn. I've learned a ton over all these years. I challenged my care team to live the life of a CF patient. Now, I don't mean that they're going to do airway clearance therapies and nebulized therapies, but I wanted us to appreciate the time and effort that it takes. And so I challenged our team with, I want you to do something every day, twice a day, for 30 minutes. Now, keep in mind, I know that doing these therapies takes longer than an hour a day, but I just wanted 30 minutes twice a day. I don't care what it is. Go to the gym, do yoga, walk your dog, but it couldn't be, I walk a lot at work. It had to be 30 minutes dedicated to some activity that you would have to do. My dogs loved it because I got out of bed before the light came up and they got their walk early on. But then I learned something. Aside from how hard it was, I fell off the wagon, and it was because of travel. I traveled, I couldn't do the same commitment, and then I couldn't get back into that routine. That's what life does. It's disruptive to that kind of routine, and why it's so hard to keep developing that, and why we keep coaching and cheering and working with people to find that routine so they can have that kind of success. We have enjoyed tremendous success. The CF story is an amazing one, but we're not finished. We need new therapies. We will always try to develop the trials for drugs that we think have meaning and will be beneficial, and do studies that are, can be completed and answer the questions that we have.